So you guys have no idea how much of a unicorn that man really is. Jay, you don't do work in Florida, right?
Pardon?
You don't do work in Florida, do you? Are you doing work in Florida now? Florida?
No.
Okay,
No.
I didn't think so. So trying to find an independent TPA that in the state of Florida was an extreme challenge for us, and somebody that was actually willing to work directly or independently without some cost plus markup and doubling the price of our services and taking their cuts and inserting themselves in, or some UMR platform that truly is an independent processor of claims. It is very difficult. But FMMA is finding these people now, and they're starting to grow their connections with some of these independent TPAs around the country. So they are getting a little bit easier to find, but still definitely a unicorn. So part of what we've done this morning really is to try to sort of gather data as to what is the problem. As physicians, we're designed to explore the problems, to ask questions as to what's wrong with the patient, to gather data, and to form a diagnosis, and then come up with a treatment plan. And that's kind of what we've done this morning, is really analyze what the problem is with the system and breaking it down. But the information that Jay and Phil and everybody else has presented this morning has taken me so many years to gather this information that even every time I still hear them, I'm learning more each time. It's very complex, and so when I see these questions of how do I do this, how do I do that, some of this stuff is extraordinarily complicated, and you're going to have to learn as we go. But just kind of bringing it back to our practice and what is possible, and what are the abilities of you and your practices are able to do to change the cost and to bust, not just bend, but bust the cost curve in medicine. So most of you may know that the name of our practice is Epiphany Health, which, of course, Epiphany is a really silly name for a medical company, but in fact, we had our epiphany, much probably like many of you had your epiphany. And the epiphany came actually from an employer. The employer approached us and said, my insurance premiums keep skyrocketing. I'm paying an insurance company to pay you, and all my employees see you. Why am I hiring an insurance company to pay you? Why don't I just hire you directly to take care of my employees? And that was sort of our epiphany moment, is why are we using an insurance product to pay for primary care services? And so we started to explore how we might be able to work through this and create an insurance-free platform that we could work with this employer. And what we realized as our epiphany was that it was the insurance that was actually driving up the cost of the care for our patients. And we saw a lot of this. It was the outside factors that everyone sort of explored. It's the hospitals, the administrative costs, it's the pharmacies, the markups on the labs and the specialists, and everything else is really what was expensive. But the primary care stuff was cheap. So what we decided to do at that point in time was we were going to create, and this was in 2010, we were going to create a membership-based primary care program, which of course all of you now know that as direct primary care. At the time, unfortunately, we didn't have a nuts and bolts conference to go to, and there was no great book on Amazon for us to buy, so we had to pay tens of thousands of dollars to lawyers and accountants and explore how to do this ourselves and sort of fumble our way through as we learned it. But what we essentially did was we created a comprehensive primary care service. And we said, well, what does a primary care doctor need to do his or her job well? Well, we need access to affordable labs. We need access to affordable imaging services. We need access to affordable physical therapy services. That's just our bread and butter. And so we reached out to our independent mom and pop operations in the area and said, if I could approach you for send you a cash-paying patient, what would you accept for your services? And you'll see down the line here what our actual costs on these services. But one of the things that you've heard a lot today is we keep talking about the free market to medicine. We need to return the free market to medicine because, as we all know how the market works in the United States, you've got an LCD television that comes to market, and it's wonderful, but boy, is it expensive. But we start making it better, start making it cheaper, start finding better ways to produce it, and before you know it, that $1,000 television is a $300 Black Friday special at Walmart. That's the free market in action, competition, choice. And then we look at healthcare and say, well, we've had competition in healthcare. We've had a free market, and look what happened. This is insane. The prices are skyrocketing. We can't go back to the free market. It didn't work. We have not seen the free market in healthcare. What we've seen is competition in a price-fixed system with no price transparency. And then you look at this, the EpiPen. You see what happened with this EpiPen? This is 10 cents worth of medication. We put it in a proprietary delivery device. We make the government buy it, and all of a sudden it's $600 a pen. That's the free market in action. That's capitalism destroying healthcare. And in fact, no, what that is that's crony capitalism, some being lobbying for Congress to purchase, mandatory purchase of a pen, and it obscures the actual cost of the delivery. So there is no true competition in a system like that. So we talked many times today about why health insurance is so expensive, but if we were to go ahead and take all of healthcare and put healthcare in a box, and we're going to sell that box as an insurance product, and in that box we're going to put our nice affordable primary care. But we are also going to put in end-of-life stay, pacemaker surgeries, hip replacements, every expensive imaginable thing, the what-ifs. We're going to put that in the box, and we have to sell that box at one price, and that price is extremely expensive. It actually artificially raises up the cost of access to primary care. But when we split off the primary care from all that other stuff, the cost of access to care comes crashing down. So separating the insurance from the predictable. Now the insurance product is affordable, as we saw with Chad's slides this morning. The primary care is now affordable, using the insurance properly. So this is what I see as the insurance-based primary care. This is a toothbrushing machine, very complicated. Taking something that's extremely simple and making it very complex. That's basically what primary care in the insurance delivery model looks like. But as you all know, the direct primary care strips out all that and makes it just a basic, simple relationship between the doctor and the patient. And as you've heard many times today, it separates routine care from catastrophic care. We have a clearly defined package of services that allows catastrophic insurance to truly be true insurance, again, not prepaid medical services. And it allowed us to offer complete price transparency, which was unseen. So in our program, we bundled in 25 office visits. We have transparent pricing on Pap tests. As you can see our prices on that slide there. And I would add that those prices have not really changed in many years. We'll see that a little bit later. Our pricing for this is $60 per month per individual, and $25 per month for the first child, and $10 a month for each additional child. After that, we don't charge anything for office visits, no copays, no deductibles. You guys have seen how this all works. Joint injections, EKGs, any procedure that can be done in the office is included at no extra charge. Laceration repairs. But what a lot of questions that get asked at a conference like this is, how do I start to do something like that? How do I begin to find a cash price on these things? Well, quite frankly, you got to start by just asking. It's amazing what you can accomplish just beginning by asking the question. So we went to our independent labs, or we went to our independent imaging centers and said, do you own your CAT scanner? Yes. Okay, so is your CT scanner running 24 hours a day? No. Okay, so if it's not, what would you sell me an unused CAT scan for? If I could, send you a cash-paying patient, you don't have to deny or don't get denied services. You don't have to worry about prior authorization, step edits, get cash. What could you sell it for? And we were seeing massive, massive savings on these things. We reached out to our independent labs and said, if you didn't have to bill the insurance company, submit the codes, get the codes denied, wait 6 months, apply it towards deductibles, and chase the patient down, what could you sell your labs for? Because if you ask the lab what the most expensive thing they do, they'll tell you it's labor and collecting their bills. It's not processing the labs. The processing of the labs is the cheapest thing they do. So when you strip out the labor, the cost of these things come crashing down, traditionally about 95% discounts. So what we've also done is we've started to build a coalition of like-minded specialists in our community. And we'd reach out to our cardiologists and say, we're going to go ahead and send you patients, and we don't want you to cringe when we pick up the phone and call you. So we call this our no cringe test. We say, I just want the list of 10 of your most common procedures, 10 of the most common things you do, and just give it to me, put it in writing, and our patients agree to pay you in full at the time of service. And so we have developed a list of services available for our patients in the entire community. And so we now have a hospital on board, and I can thank Dr. Smith for this one. Funny story. So this was about 3 years ago. We were in Dallas together. You were talking for us down in Dallas. And I get a phone call, and it was a hospital administrator from a rural critical access hospital about 45 minutes from our office. And he said, Dr. Gross, this is the CEO of the hospital, and I know you don't know me, but we've been following your work. And he said, have you ever heard of Dr. Keith Smith, the Surgery Center of Oklahoma? And I happen to be sitting with Keith at lunch. And I said, it's for you. But he wanted to replicate the stuff that was being done in Oklahoma City. And he said, you know what, I think we can do that bundled surgery here. I think we could do those bundled prices. And this is something that we'd like to offer to you and your patients, is that price transparency and bundling. So we have a hospital on board. We have 2 labs, 3 physical therapists, 4 imaging centers. I think it's actually higher than that now. We also reached out to the independent pharmacies, and I know a lot of people in this room do dispensing directly to the patients. That is not something that we have done in our office. What we started doing is reaching out to the independent pharmacies and said, hey, if we send our patient to you, will you work on a cost-plus basis for us? So wholesale plus 3%. And we worked out arrangements for them to be the pharmacists and working with our patients. Well, it turned out with the GoodRx pricing that many of you know about, we were getting very similar prices for our patients. So we've actually not used a whole lot of those anymore, but still the prices of the direct wholesale to consumer are still a lot cheaper than what we're doing at the moment. We have optometrists we're working with, we have some dentists that are providing services, and we now have a whole host of specialty care that we're working with. So our pricing, just similar, I think, to Chad's prices this morning, about $500 on a nuclear stress test. Our CT scans of the chest are about $200. Carotid, our ultrasound's $120. The colonoscopy is an interesting thing. We're also working with this hospital and trying to determine the pricing on the colonoscopy, and they said, well, if it's a diagnostic colonoscopy, or it's going to be $1,000, and if it's a screening colonoscopy, it's going to be $800. I'm like, well, it's a colonoscopy. Why do we care what we call it? Let's just go ahead and come up with a price and charge the price. But the neat thing that we were able to do with our colonoscopy is we were able to bundle it with the pathology services. Because frankly, it doesn't matter what we call the colonoscopy and what we charge for it. If they get a $3,000 surprise pathology bill in the mail, it doesn't matter. And so what we were able to do is say, okay, we're going to go ahead and bump up that price just a little bit. We're going to go ahead and include that pathology service. The hospital was willing to bundle that pathology in there. So the price is the price. There are no surprise bills, whether they do biopsies, no biopsies. And our price on the colonoscopy, I think, is $1,100. So that is the price we did before we did the bundle, and that was a couple of years ago. But we're about $1,100 for the colonoscopy bundled with the pathology. Our chest x-rays are about $20. So this is an actual hospital bill, and if you guys have seen my talks, you've seen this before. Full disclosure, I'm on the board of this hospital, and they still don't like me traveling around the country showing it. I'm still waiting for them to fix the problem. So I'm still showing it. Okay. So this is an actual bill of a patient that went to the ER for abdominal pain. And I'm going to summarize it in the next bill, but this is just to show that it is in fact a real itemized bill. But we are able to see patients in our office same day. We're able to get stat labs, stat imaging services, and in fact, since our schedule is designed to see people within a couple hours, oftentimes we see them in our office quicker than they could be seen in the emergency room. And so a patient comes in, that hospital bill came to about $20,000. So you guys have seen this before, and you know how this game ends. So that $20,000 in hospital bills, what do you think our price on those exact same services would be? $9. That's good. Close. $301.29. So that's CT scans, that's blood work, that's the physician services, that's the chest x-ray, everything out the door. That would be the cost to our patients. So this is a fun story. You'll see a lot of these familiar faces here in this room. So, Elena. Hello. Elena George. Elena is an ear, nose, and throat surgeon in Atlanta. She'll be speaking tomorrow. And she does a lot of work down in Antigua. And she, when she was down there doing some of her work, diagnosed a patient with thyroid cancer. Of course, that patient had no health insurance, and so a thyroid cancer surgery in San Juan, which is about where most of those patients probably would go, would be around about $100,000. So she called up Dr. Smith in Surgery Center of Oklahoma, and he said, yeah, we could do that. He said, but the problem with thyroid cancer is patients can need about 6 months of preoperative and postoperative management. They're going to need assessments. They're going to need imaging. They may need medications. They're going to need an endocrine consult. So it's not just a matter of doing surgery. The patient actually needs some medical follow-up. And he said, Florida's a lot closer to the Caribbean than Oklahoma City. And so Dr. George and Dr. Smith reached out to me and said, would you be willing to co-manage this patient with us? So patient did come to the United States. She came to us, and she was here for 6 months. We did the imaging, we did the workup, endocrine consult, all the lab work, sent her and coordinated with the surgeons in Oklahoma City. She flew off to Oklahoma City, had her surgery, came back, did the follow-up with us, blood work, got her on medication, 6 months. The total for all of that came to about $10,000. Unfortunately, I have not heard from this patient since the hurricane, so I hope you have. So I told you about what we're doing with this hospital. We're now bundling surgeries. We're bundling knee replacement surgeries. So typically an uninsured knee replacement in the United States, generally you've got of course your charges, but then a lot of these uninsured patients, they could pay $45,000 to $60,000. So these people are traveling out of the country. They're traveling to Singapore. A surgical trip to Singapore for a knee replacement is about $18,000 to $22,000. So at the hospital we're working with down at the bottom there, our price is $18,550. Now, that price includes the implant, it includes the surgeon, it includes the anesthesiologist, and it also, in this case, included a week's stay for rehabilitation services. And so the interesting thing about this phenomenon is that when this patient went to the hospital for this, they came with a check. Patient comes with a check in the hand, and the CEO called us up and said, this is fantastic. What we did was we went ahead and got the patient Egyptian cotton sheets, and we got some flowers, and we put some balloons in there, got the room real nice. It's like, and we're going to go ahead and set up a catering menu. We're going to go ahead and have food delivered in. It's going to be really nice. And we're going to hire a private duty nurse because private duty nurse is the way to go. We brought in our surgeon from out of the community that generally wouldn't operate in this critical access hospital. And I said, well, just out of curiosity, what does Medicare pay you for that? He's like, about the same amount. I'm like, well, what's the difference? He said, Medicare doesn't pay us in advance. So on the one hand, the patient is treated like royalty. This was the kind of treatment that we would see patients coming to us. When I worked at the Cleveland Clinic, you'd see kings and queens coming in and getting that sort of level of treatment. But because the patient was the one with the check in the hand, the treatment was completely different. So Chad alluded to this a little bit earlier, the cost of coverage in the United States. As of last year, this is an employer-sponsored plan for a family of four. PPO is it's actually now probably closer to $27,000 this year, $25,000, of which the employee's portion of that now is over $11,000. Okay, so that's the employee's out of pocket between co-payments, deductibles, and so forth. And so I already just shared your story. Your once-in-a-lifetime cancer event, we cured for $10,000. So what are we paying so much money for insurance if your once-in-a-lifetime knee replacement, or I should say your twice-in-a-lifetime knee replacement, perhaps worst-case scenario, is $18,500. And so if you can cure the once-in-a-lifetime event for less than your 1 year out-of-pocket expense, why are we using insurance to pay for all these things? So since I'm talking about the skyrocketing costs of healthcare, this is the actual cost of our membership since we launched. We have actually lowered our prices. This is healthcare inflation in the DPC world. So if we look at the difference between the cost of coverage versus the cost of the care, so in my practice, a direct primary care for a family of four for a year is about $1,800 per year with the membership fees. No copays, no deductibles, you know how that goes. The PPO plan that I showed you for a family of four is about almost $26,000. So the difference between the coverage versus the care is about $24,000 per year. Chad kind of alluded this also to in some of his numbers before. Well, those bronze plans now, you're seeing again about a $7,000 deductible. These are ACA plans. These are the plans we're fighting to keep access to. Is $7,000 out of pocket and a $14,000 out of pocket for a family. So if instead,
It's gone up.
oh, yeah, that 7350. So the costs have gone up. So for this family of four, what I want to do is do a comparison. So Chad showed you that slide, and Jim Parker talked to you about how the administration expanded access to these short-term limited duration plans. And so for fun, what we did was we compared a short-term limited duration plan plus a DPC membership versus the Millman index for the PPO over 10 years for this family of four. And what we saw on that red line on the top, that Millman plan is going to cost you about $28,660. That's just the premiums. Then you of course have your employee contribution to all that sort of stuff. And across the bottom, that black line, $39,960 is what the DPC plus the major medical plans are. And what you'll see over 10 years is that those green lines is about $250,000 in savings for that family of four over 10 years. And people say, well, wait a second, people don't have that kind of money to pay for something major if it happens, because look at that plan has about a $10,000 deductible. Who has $10,000 set aside? Well, let's just say that family is the sickest family on the planet, and they come $10,000 out of pocket every year for 10 years. Take $100,000 off that $241,000. Okay, so now you've only saved them $140,000 by using it as insurance. That's the worst case scenario. That's assuming they hit it every year. Well, most people won't do that. So by using insurance better, by using insurance as insurance, you now have the actual ability to save money in years where you don't hit it, but use your insurance as insurance when you do hit it. And the savings for a family, the savings for our country, the savings for employers are astronomical. And it's the slide like that that has people beating down his door to get to you guys. I mean, those are real dollars that are coming out of people's pockets. And so, you know, what does that mean to, I didn't mention it, but this hospital actually, they were so happy with how things had gone with our sending surgical patients to them that they actually decided they were going to restructure their benefits program and offer DPC as a benefit to all the hospital employees and their family members. So we now actually have a hospital that's basically a DPC hospital. And it looks like the savings in the first year, because we were able to find an independent TPA to work with, we're still rolling this out, but we're looking at about $500,000 in savings in the first year alone. And so, you know, you extrapolate that to a community hospital now. So that means a ton to a critical access hospital. So now if you open that up and you say, okay, we're going to go ahead and open that up to the school board, the county, the city, and the potential savings for this rural critical access community is millions of dollars per year. That means raises for employees, that means new equipment for schools, that means keeping your care local, and you do have a way of revitalizing and keeping care local and saving these critical access hospitals through restructuring these employee benefits, letting doctors be doctors again, and restoring healthcare control back locally. So, looking back at the Affordable Care Act, the assumption of the Affordable Care Act, if it had worked perfectly, was that we were going to go ahead and insure 32 million people, but the assumption is that we would leave 26 million people uninsured with that program. And the cost on that projection at the time was about $1.8 trillion. So if instead of doing that, what we decided to do is we're going to go, and that's just for the coverage. As you know, the coverage does not necessarily give you care. The coverage gives you maybe an ER visit, but it does not actually give you access to anything in particular. And so if instead we went and gave a DPC membership or access to a DPC membership to all 58 million uninsured people in the United States, the net 10-year savings compared to the Affordable Care Act would be about $1.4 trillion. So now what we have is the basic access to care for every single person in the country that has no insurance. That $1.46 trillion could go a long way towards social safety nets, whatever you want to do to provide for the patients with the true chronic medical conditions that may hit that $10,000 every single year. But you can use this money in so many different ways and restructure things in such a way. But what this is saying is that by physicians retaking control of healthcare, by bringing back and restoring the power to you and to the patient, by taking the power away from the insurance companies, you know, they can't do this without us. They need us. So, you know, we are allowing them to use our services and to rape and pillage the American economy, and I think we have the ability to take that back. You guys have the power to control this, and I encourage you to use your power wisely. Thank you.